Hi, and welcome to our Basic Income webinar. I'm here today with Hugh Segal and Dr. Andrew Pinto to talk about this bold new policy that we're promoting as part of Eat, Think, Vote. And before we start, I'd just like to say a few words about who we are at Community Food Centres Canada. We bring resources and ideas to build new community food centres across Canada, community food centres that grow, cook, share, and advocate for good food. We started at the Stop Community Food Centre in West Toronto, and we've grown to Regent Park, Stratford, Perth, Winnipeg, and we're welcoming our newest centres in Dartmouth, Calgary, and Hamilton now. As well, we work with the broader community food security movement to convene conversations on big ideas like this one and to create a community of practice for organizations doing grassroots food work through our Good Food Organizations program. The core of our work is food, or the lack thereof, but we can't talk about solutions to household food insecurity without taking in the broader picture. 4 million Canadians are suffering from some level of food insecurity. And food security is not just about poverty, but there's no question that poverty is the single biggest contributor. And while we do lots of great things at the grassroots to help people take charge of their lives, there's no way that we can fix a problem of this magnitude. Problem as complex and huge as poverty and food insecurity requires social policies that address the problem at that scale. We're convinced that the time is coming or has come that Canadians won't accept the growing gap between the rich and the poor, and that we'll all start to see that it's not just other people's problems but our own. As our economy changes and we find that many more people get replaced by robots or work in precarious jobs and our kids can't find work. Politicians have been hiding from this issue for some time, seeing it only as a political liability, but it's time that they start to contemplate bold policies such as the one we're discussing today, basic income. Basic income is a policy that would see all Canadians guaranteed a very basic income below which they couldn't fall, regardless of factors like job loss, recessions, going to school, or taking care of the family. When we first heard about and started considering the idea, it sounded like a pipe dream, but suddenly it seems as though there's been a groundswell of sorts. And while it's still perhaps not something that's going to be implemented overnight, it's at least on the agenda in various jurisdictions in Canada and around the world. So today we have with us Hugh Segal, who's a retired senator and now master of Massey College and has been a voice on this issue for 30 years. We have a more extensive bio on the website, but importantly with Art Eggleton, he led the Senate committee that published In the Margins, a report on poverty and homelessness in 2009. And Dr. Andrew Pinto is a primary care physician and scientist at St. Michael's Hospital in Toronto, who's been involved in the income security clinic there and is researching the effects of boosting incomes for low-income patients. So the format for the webinar is going to be that we're going to have a discussion with the panelists for 40 minutes, followed by a short appearance from Diana Bronson, the Director of Food Secure Canada, who will be sharing what they're doing right now across Canada to make food security an election issue. And then we'll have about 10 minutes for audience questions. So you can send them in via the chat on the right side of the window to the host. And I think you can do that at any time throughout the webinar. So to get started with our questions, when did you realize that the current approach to poverty wasn't working and that we needed to address it in a different way? Is there a story, a moment, or an issue that opened your eyes for us?
For me, it was in the mid-1970s. I was working as a junior member of Mr. Davis's staff when he was Premier of Ontario. And the two opposition parties had brought in a motion of non-confidence in one of the committees on the Minister of Social Services and her Deputy Minister, and a motion to reduce their salaries to $1. They were so angry because the reality of senior people, senior citizens in Ontario was that they were mostly women and they were largely poor. 35% of them were living beneath the poverty line. And when that became clear and apparent, and the Toronto Star and others were doing stories on older women who are actually buying dog food and cat food to add to some protein content in their diet, the government said, we can afford to fix this. We have to fix this. These people have worked all their lives to build a better Ontario. We owe it to them. 3 weeks later, they brought in the Guaranteed Annual Income Supplement, which said, if you file your taxes and you're earning beneath a certain level in total, you'll be topped up. And that brought that 35% poverty level amongst those folks down to 3% in 2 years. So I said to myself, if we can do that for seniors, why would we look the other way when we know there's all other sorts of Canadians who are living beneath the poverty line and producing huge problems for themselves in terms of health and other bad outcomes. That's when the notion for me crystallized that this was something we could do.
Thank you. Go ahead, Andrew.
For me, it was really, I guess, throughout my training in medicine and starting residency in family medicine in a downtown inner city practice at St. Mike's, that I saw in so many of the patients that I was working with the impact of poverty on their health. One patient's story sort of stands out. It also relates to food, where a patient who I was working with who was on basic welfare said, we were talking about his diabetes and how to control it, and he sort of said to me, I can't remember the last time I had anything fresh to eat. And it was that sort of stark reminder that really we can advise people about things like diet and what's healthy to eat, but at the bottom of it is that they're just struggling to survive on incomes that we give people. And you also see this in people who are, in my patients, who are holding out to when they turn 65, where they would actually see a significant increase, but they're in their 50s and they see ahead of them a whole decade of still living in this sort of life before they can get to that slight increase in their income. So it's those sorts of things that really, I think, affected me around realizing that poverty is at the root of a lot of health issues.
Great, thank you. So I'd like to start with a little bit about your work, which is also at the Grassroots in a Way at St. Mike's. You're part of a team that's been prescribing income to low-income patients. So you refer people to a health promoter who helps people to take advantage of the government funds that they're entitled to. You can actually give people checks, I guess, to increase their income. And actually, we do a similar program at community food centers that also tries to connect people with entitlements. And I see this as ways for people to take matters into their own hands with your help, while we're working towards these greater changes that we need. But there's a lot to be learned from the impacts that this kind of increasing incomes can have on people. And I know you're doing research to that end. So can you tell us a little bit about the symptoms of poverty that you're seeing and how these income prescriptions are helping to solve those problems?
Yeah, it really has emerged from this recognition that poverty is a major determinant of health, but we often lack the ability to really do too much in the clinical space. So we were fortunate to receive support from the Ministry of Health to hire a health promoter who focuses on income security for our patients. And she's been now joined by a second colleague who's focusing in this area. And it's really in three main areas. One is helping people increase access to benefits and grants, complete their taxes, and navigate sort of systems like that. Another is looking at their expenses, seeing if there's anything that they could avoid, such as check cashing places, things that are costing them a lot. And a third is areas around financial literacy, so that they understand how their funds work and if they need to connect them to community resources. And some of the early lessons that we're learning from this are that many of the people referred are dealing with both health issues and social issues, and they need help in both areas. So really, it's about the health promoter working with their physician or nurse practitioner or the other members of the health team to help them in both spheres. Another is that many of the folks being referred are newcomers to Canada. So these are folks who are not as familiar with our systems and often need some support, just learning how to navigate, but then they're able to do well. And then a third sort of issue is that there's of course some limits to what we can do. And it's still, we're working within a limited system. For example, the social assistance system in Ontario has significant limitations and lots of things that keep people really from increasing their income and moving forward. So we see it as part of the solution, but it certainly won't fix, of course, the bigger problem.
And are you seeing the positive impacts when you're able to connect people with these resources?
Yeah, I mean, we're still in the very early days of this, so we're at the point of looking back at the sort of first year or so of this program. We're refining it, and we're also talking to other health organizations about how we do this work. But some cases that we're seeing where people who do, say, get a move from basic welfare to ODSP, the Ontario Disability Support Program, they see a significant increase in their income. And it does mean that they have more stability around housing. They're often able to move out of shelters into actually their own apartments. We've seen a fair bit of help moving people into better help around medications and understanding where they could get coverage, even moving them to less expensive medications. So there's been a few examples, and we're compiling sort of some case reports in this area.
Great, thank you. Yeah, I mean, doctors are such a key part of that issue of moving people from from OW to ODSP, for example, and it can make such a huge difference. So on that larger scale, in terms of health policy, are you seeing a shift in the medical community or in government policies towards more of an approach that takes social determinants of health into account?
Yeah, in the health world in Canada, I've really seen, even since I've finished medical school, I've seen a big change in how people think about social determinants and the amount of interest. There are now guidelines around addressing poverty that the Ontario College of Family Physicians has helped support, with Dr. Gary Block, one of my colleagues, playing a really key role in that. We've seen the College of Family Physicians of Canada issue best advice guidelines around addressing social determinants at the clinical level, at the organizational level, and then in terms of advocacy. And we've seen even groups like the Canadian Medical Association take this on. I mean, one thing which I'm sure we'll get into is the Canadian Medical Association at their last annual general meeting this August passed a resolution supporting the idea of a basic income and the idea of doing pilot work. So we're seeing lots of interest in this area. I myself and about 200 physicians in Ontario wrote a letter to the Minister of Health here, Dr. Eric Hoskins, around the idea of also studying a basic income for Ontario. So there's significant interest in the health world, and it's becoming a lot more acceptable to think about and try to address these issues, although I think we're still really needing to develop the evidence around the intervention.